Hi, so I'm Nolan. Pretty sure some of y'all know me already. Some of y'all met me at Dr. Mark's clinic, his pulmonary clinic. So I am the registered respiratory therapist over there that does the breathing test or pulmonary function test, as y'all know. I am a St. Philip's alumni. I graduated in 2017. Yes, I did have Krista Mitchell as my teacher, and she is actually the reason why I found a job. So definitely be nice to her, definitely give her respect, and definitely keep contact with her. So I just want to say, yes, I am Krista Mitchell's favorite student of all time. So that's why I'm also doing this. So basically what I'm here to do is I was going to try to be there in person, but unfortunately with scheduling and also with COVID, I cannot do that. So I'm making a video at my house, being recorded by my lovely fiance, gonna get married in less than 2 months. So she's helping me out here so I can actually help y'all out. And basically from a student perspective and a alumni perspective, as someone that actually knows the test and actually performs these tests daily, to actually help y'all basically try to make it a little bit more simple. So basically, so everything that I'm gonna go over I should be able to help you and kind of dumb it down a little bit. So when you do these breathing tests, guys, it is more simple than you think. I know that it's boring, or some people find it boring, but in reality, it's like actually a great diagnostic tool for these patients for their prognosis. So when you do PFTs, it's much more than just scheduling, why a lot of people actually like it. It's more of a coaching and being able to see a picture that you cannot see anywhere else. It really does help when you're actually able to coach a patient to be able to do their best of their abilities. You see something that you can't, and you help these patients, and you help them by, just like what I do is I help them, give them to my providers, my physicians. I help them by giving the best data I can possibly get, and doing so I can get them to get basically on a regimen or something to help see possibly how obstructed, how restricted they are. So I brought a few tests home to kind of help go over everything. So basically, the things that I'm really going to go over are three things that you need to know for your test, for your boards. And not only that, I'm not sure if Krista has given you your pulmonary function test yet, or it's coming up. I think it might be coming up. So there's a couple questions I actually do remember from back when I was in school, back when I graduated 5 years ago. Not to brag, but I did have the highest grade then too, so go figure, I'm in PFTs now. So I was in love with it then, and I'm in love with it now. So for the ones who are already skipping along, the more nerdy ones, they're gonna recognize some of the terms and the phrases what I'm gonna go over. So the ones who, there was a few people that actually have met me and been to my clinic and had spoke with me, and I was actually surprised with how thorough they actually got from just me speaking with them. So first, guys, there's three things, what I was saying, three tests that are mainly for the board. So that's going to be your spirometry, that is going to be your DLCO, or diffusion capacity, and also your lung volumes. So I'll start off with my spirometry. Spirometry is going to be your basis of everything. That every pulmonary function test question that you have on your boards will be about spirometry. We'll have everything on spirometry. Spirometry finds out everything. You get the basis of that for every test. That is your test that you do for everything. Depending on where you go and where you work, that will be able to tell you if you need to do lung volumes. Where I work, that needed to tell me if I just need to do a post-treatment or more stuff. And I can figure out a little bit more or less if I need to do other things or recommend other things to Dr. Marks. But just testing purposes, you're able to tell out if they're obstructed, if they're restricted, or possibly normal. What I did to help me, I looked up a graph, and I know there was a couple students I spoke to already that I showed them the graph where you look at where to start from and where you can go to help diagnose what they are. So from where you start, right? Spirometry, you're really realistically only looking at 5 important things. That's going to be your FVC, that's your forced vital capacity. You have your FEV1, that's your forced expiratory volume over 1 second. So how much you're able to blow out over 1 second. You have your ratio, and all that is your FEV1 over your FVC. You have your your FEF 25-75. All that is how much you're able to blow 25 to 75% of your breath. And you also have your PEF. That is how hard they are able to blow out. So how I start. So Krista's going to teach you for spirometry based on American Thoracic Society guidelines, and also based on what you're going to learn on the boards. You need three maneuvers that are almost identical, and each one of that, I said, out of those 5, each one has different each have different numbers that you have to look at that can be between each other. Meaning, like my FVC is forced vital capacity. All that is simply how much are you able to blow out from when you completely take that deep breath in, how much are you able to blow out until you're completely empty? That's all it is, plain and simple. So if your number's high, I want you to think of the grade system. If your number's high, 100% is normal, right? If your number's low, 60, think of you failed, okay? So these numbers have different ranges. 80 to 100 is normal. 79 and below, you want to start thinking there's some type of restriction. And depending on where it is, it could be like, that's where you start finding out it's mild, moderate, or severe restriction. So based on that, I'm going to leave the numbers up to Krista. She can go over that to more in detail. But FVC, all I want you to think, 80 to 100, that's normal. Anything below that, I want you to start thinking restriction. So when you remember this, when you start going over PFTs and also in your boards, there are 5 obstructive diseases. That's it. Everything else is going to be restricted. So you have CBABE. Krista already taught you that. That is your cystic fibrosis, your bronchiectasis, your asthma, bronchitis, and emphysema. Everything else is going to be restricted. I'm talking about post-COVID. It's going to be restricted. Pulmonary fibrosis. You can get that from severe post-COVID. Obesity. Obesity is something restriction that can cause restriction. Pneumothorax, pleural effusion, all those things are causing restriction. All that means is you have less volume. Obstruction, yes, they kept saying you can't blow it out, so you have more air to go. You have more air in your lungs. So FEV1, that is all that is your speed. So I want you to, same thing with that number as well. It's 80 to 100. So everything else below, if for your FEV1, now that's a little different. If it's 79 and below, you want to start thinking there's some type of obstruction. Well, I just said obstruction, you can't get it out. It's gonna be slow. Now, if you are restricted, you don't have a lot of air to get out, so you should be able to blow out pretty quick. Now, if there's some type of mixed, you'll be able to see that a patient has a high FVC and a low FEV1, meaning he has a mixed would be maybe their FVC, right? Their total amount of air they have to blow out, let's say 78. So that's restriction. But your FEV1 would be, let's say 50. I'm going really exaggeration, and I've seen that. That means they didn't have that much air to give, your FVC, and your FEV1, they didn't blow out that fast. That's a mix right there. So you'll be able to see it right there. So think of FVC, your total amount of air blew out, and then your FEV1, that is all about speed. Something that also correlates with speed is your 25 to 75. Now, it's not a great way to help diagnose it just because it's more of an effort dependence, meaning some people can actually blow out a little longer and some people aren't able to really force it out. It's more of an effort dependence. There's a lot of things to that. So that is not a good correlation. We don't look at that, and even on American Thoracic Society and also the boards, we don't use that to match. That doesn't have to match with the others. Now, as a good therapist, I want it close together, of course. The ones that need to be close are FVC, FEV1, and your PEF. Those three need to be close together. And I'll kind of go over that in a second. So your 25-75, that also relates to speed. So 60 to 100 is normal. 59 and below, same thing. If your speed is low, it's more of an obstruction thing. Now, if it's a high thing, I'm either thinking it's a normal or restriction. I'll keep going up how I go step by step. So, and your PEF, that's your speed. So I did have a question on my time multiple choice test, my boards, where I had a spirometry question that said, what is the main reason of the difference of all the numbers, all the values that I had? And I looked at everything, all the numbers I just said, my FVC, FEV1, my ratio, my 25-75, and my PEF. Why were the numbers different? And it was a simple one. My PEF, again, that is how much force you were able to blow. There is a certain percentage that they need to be close together. There's not a certain number, they have to be close together. The boards make it pretty simple, and I'll explain why. So all the PEF numbers were different. It was like a 2, a 5, and a 10. That's completely different. And they make it exaggerate. So guys, I just want to emphasize with the pulmonary function test, and actually on all the TMC questions, and a little bit with the with the ClinSims, these people aren't asking if you exactly know the values. They're asking if you know it or not. Do you know it or not? Do you know if it's obstructed? Do you know it's restricted? They're not going to be asking you what are the ranges. Yes, you should know it. It will help you. But it's the same thing with bicarb. When you're doing an ABG, bicarb, I've seen a book where it was 22 to 26. I've seen a book where it was 21 to 28. There's a difference. On the boards, they're going to have a perfect 24, 25. Or they're going to blow it out proportion and have a 34. You'll know it. All books have different values. Same thing with the PFTs. There's different values, but based on what we go off American Thoracic Society values. So basically, you're gonna think FVCs 80 to 100, FEV1 80 to 100, ratio FEV1 over FVC is 70%, and your 25-75 is 60%. In that order, that's how you're going to see it on the boards. That's how Mitchell's going to have it on her test, and that's how we have it on our test. In that order, those four. And then we also have the PEF at the end, but I look at that lastly. So how I look at it, here, you can pass me it. How I look at it right here. So I brought some PFTs home to show you guys. So I crossed out their name, so if anybody wonders, I did this so I don't get in trouble, HIPAA laws. So this is what I was talking about. FVC, FEV1, you got your ratio. You have a 25-75. Don't worry about this one. And then PEF. So this is a normal PFT. So I brought a few PFTs home to exactly show what I mean. So how we do it is you start with your ratio. Your ratio, like I said, it's 70%. 70% or higher, I'm thinking it's going to be either restricted or it's going to be normal. But one number will not tell the whole story. You're getting an idea. You have to follow along to figure out everything else. After your ratio, so this is 86. So I'm thinking this is either going to be normal or restricted. Then I go to my FVC or FEV1. My preference, I like my FVC. FVC, I figured out if it's high. I'm either thinking it could be obstructed or it could be normal or hyperinflation. So, but again, I had to look at everything else. So my FVC is 110. So I'm either thinking, like I said, normal, obstructed, or hyperinflation. But let me look at the speed that it's at. And I'm looking and it's at 111. So that's why the ratio is 86 and it's 86 predicted. And so both of these are normal right here and this is normal. But let me look at the 2575 to really see, because I've seen it where all of these are normal and the 2575 is like 40. So I have to look at that as well. So I go down and the 2575 is 120. So based on this number right here, this is normal. So again, 80, 80, 70, 60. That's what the numbers I'm looking at. The PEF, again, you don't look at the numbers. You mainly look at, see if it matches with your other numbers, your other PEFs. So, because I've seen it also where they blow out low, but that's where they are. Their PEFs is their force, their muscle strength, how fast they're able to blow everything out. So this is a pretty normal one right here. She did good, yeah, so this was a 5'1", female, 38 and 130. And guys, now that you're on your PFTs, a question that Mitchell has on her tests are, what are the 4 things that base a PFT? And it is going to be age, height, ethnicity, and sex. Those four alone. That's good. That's what it is. So again, so your 4 that are going to base your numbers are your height, age, sex, and ethnicity. Weight does not matter. Now it can affect if you're restricted or not, but I won't go into that right now. So right now, this one, like I said, this is normal. The second test where I was going for is your diffusion capacity. Your diffusion capacity is, all of that is your ability to absorb what we're breathing in right now. What I tell these patients are, so what we're doing for that test is we're actually giving you a gas that we can measure. And the gas that we give, and again, this is Mitchell's question, is carbon monoxide. It is a trace of carbon monoxide. The reason why is it absorbs into our bloodstream and our gases and goes through our AC membrane and all the other stuff, goes through our alveoli, all the good stuff. It goes through it relatively quickly, as that's why we have carbon monoxide poisoning. So we actually have a trace of carbon monoxide that we give. So you're holding it, and we have to hold it for a minimum of 6 seconds, okay? So you have to at least get 90% of what you just took in a breath in right now. I don't believe that's a question, but just know you have to hold it for at least 6 seconds to get the diffusion capacity going on. So you have to let them absorb it, let it go to your bloodstream. And then when you breathe out that last time, we're actually seeing how much did you absorb. So if a patient breathes out the carbon monoxide, that's not good. That means their body didn't absorb it. So this number would actually be low. If their body did absorb it, that means that's a good thing. We want your body to absorb. That means you're able to breathe right now. You're able to, you don't have any difficulty breathing. So right here, based on this, well, all you're going to look at for diffusion, all I want you to really look at for y'all guys and y'all's boards to make it real simple is your DLCO. It's same thing as your FVC and your FEV1. 80 to 100 is normal for the percentage. 79 to 60 is going to be a mild decrease in diffusion capacity. 59 to 40 is a moderate decrease in diffusion capacity. And 39 and below is going to be a severe decrease in diffusion capacity. Now, what I just said, those values, I believe Mitchell will have those questions too, where you'll be able to see it and diagnose it. It's pretty simple. Like I said, 80 to 100, 79 to 60, 59 to 40, and 39 and below. So again, with this one, she did pretty good. It's over. Great. Fantastic. I love it. She was able to absorb it. Then we go to lung volumes. So with our lung volumes, this is a question also on Mitchell's exam. There are 2 ways to get lung volumes. There's plasmography, and there's also nitrogen washout. So, hold on. Okay. So, sorry about that. So, the two ways. So, here's a question. What is the more accurate way? It's going to be plasmography. So, that's the body box. The room that y'all have in y'all's lab, that big box is the plasmography box. It's also known as the body box. So, when you close that, here's another test question. What you're using is Boyle's law. Boyle's law is based off temperature and pressure. So basically, when you close the door, it calculates all the temperature and pressure in there, and you're able to find the residual volume. So that box that y'all have with the 4 columns that y'all have, which is like the TLC, and then you have your vital capacity and RV, all that right there is important. Why? Because that's how we kind of use your lung volumes. So for the boards, for Mitchell's test, everything, I want you to memorize that column box. Memorize that for good. Put that in your memory. Say it's important. It's really simple. 4 columns, all those values, real simple. So when you start doing your test, it's real simple. You breathe normal, and that's you getting your tidal volume. When you breathe out, you breathe out first, and the reason why is because of air trapping. I'm not going to go into too much detail with that unless you see me, or Lupe can explain that to you. You're going to breathe normal, and then when you breathe out first, that is getting your ERV, so your extra residual volume. So how much air can you blow out until you're completely empty, right? And then when you take that big deep breath in, that's going to be your vital capacity. So then you're going to breathe, after that, you're going to breathe normal. So the two difference between these two tests is the plasmography, the more accurate one, that's the one we close it. So that's going to be the one where you have the pat, where you just, and we're able to figure out how much residual volume that you have. So again, if based on a correct way to do it, yes, you have to find out your ERV, because when we're in that body box, we're able to tell what is the remaining amount of gas that you have, that you're able to tell with that total lung capacity. And again, you're able to tell if they're hyperinflated, right? Hyperinflated, obstructed, or restricted. Again, so that confirms what you found out on the spirometry. Spirometry can't confirm it. You can't confirm the restriction on spirometry alone. You have to get lung volumes. So for nitrogen washout, what you're doing is you keep the box open. The reason why we do nitrogen washout, it's a lot easier for patients. It's a lot easier for patients. For the big patients, depending on their size, and depending on what type of condition they're in, they're not always able to go into the body box. So that's why they have nitrogen washout. Nitrogen washout, you get a lot of oxygen, and you're just gonna go real simple. There's a calculation in a way. You're blowing out the nitrogen in your lungs, and it's able to calculate your residual volume in TLC. So this one right here, what I'm going to show you. So the two numbers make it real simple. This is going to be, I did my plasmography on this. And again, plasmography / body box is the more accurate way to find out lung volumes. So real simple. Two numbers I look at, that I looked for the boards as well, is your TLC, your total lung capacity, and also your RV, residual volume. Yes, if you want to go in more into it, you could look at your RV, TLC, and there's another, or your ERV. Me, real simple, I cut dry, because I know it's going to kind of go based on the same thing. TLC, I'm looking at this person's right here. Same thing, I want you to imagine the FVC number, so the 80 to 100, and go down. So TLC, this is 100. So before I even look at my RV 107, that means she is either hyperinflated or obstructed based on that. But if I go back to my spirometry, before I even look at my RV, there right here, 110, that does tell me that she has a little bit more air. But she with this 120, with that 2575, she had no obstruction based on the spirometry. So right here, this is telling me she probably has hyperinflation. Nothing is wrong with hyperinflation. Hyperinflation is going to be your swimmers. Those are going to be your people who exercise really well. They're good. They just have bigger lungs. Their system is just not better, but bigger. So depending on the residual volume, if you're air trapping, that means you're obstructed. If you're not air trapping, that means you're just hyperinflated. So RV is going to be a good indicator of that. With RV, if you're over 100, you have to start thinking there is some type of air trapping. But, so that was a pulmonologist at Methodist that told us that. But based on American Thoracic Society guidelines, if it's 120% or more, it's an automatic obstruction. Automatic air trapping, which means it is obstruction. So with this, I'm going to look at it and I have to really think, if it's 101%, that is 101% predicted. So if she has 107% on her TLC, on her total lung capacity, it's obvious that her residual capacity is also going to be high too, because again, we are following what's her normal, what their normal is. So if this is high, this is going to be high. So 101, okay, well, I'm expecting RV to be a little higher. Now, if the residual volume is a lot higher than this, then I start thinking there's some type of air trapping. Residual volume should not be higher than TLC. So if this was like 80 and this was the same number, 101, I'm starting to think there's some type of air trapping. This shouldn't be like that. If the lungs are smaller, this number is supposed to be smaller too. If the lungs are bigger, this number is supposed to be bigger too. And for this example, this is supposed to be normal. This is supposed to be normal as well. So to go back, to do this PFT, what I'm going to look at, ratio is normal, above 70. FEV1 and FVC, both normal. 25-75, normal spirometry. Diffusion capacity, normal, 80 to 100. And yes, higher, it's fine. It's fine. If it's higher, you're just able to absorb more. And then lung volumes, again, same numbers. This is over 100%, so it's not too big. And then 101, again, normal. So what I'm going to say is normal spirometry, normal diffusion capacity, and normal lung volumes. So a couple numbers that y'all may see in the future. I did do with this person. MVV was the maximum ventilation. She did pretty good on this too. And then I also did the MIP and MEP, which is muscle force, which all that is how strong can you suck and blow. I know that sounds funny. She did not do that good on that. So if you want to make a joke about that, I usually do with patients to make them laugh. But usually you won't see this and this too much on your boards unless you do your pulmonary function test certification and registry. So just worry about those three, what I said, the spirometry, diffusion, and lung volumes. And exactly what I said, spirometry is normal, diffusion is normal, and lung volumes are normal. So based on this, is normal. So I did a couple others right here. So before I go into this, this was actually one of somebody I know. So that's why I did not have a diagnosis. So they were pretty good. I end up doing this just so I can get everything I can, so I can have a normal PFT for the future reference. And then I have right here a pulmonary fibrosis. Again, it's not part of CBABE, so I'm starting to think restriction. So that means I'm starting to think before I even look at this, I'm not even looking at this right now. When I see that diagnosis, I'm thinking my FVC is going to be low, my TLC is going to be low, I'm thinking my RV is going to be low. I'm thinking a bunch of things are going to be low right now based on that it's going to be restriction, but I don't know the severity of the restriction, so that's why I'm going to do this. Also, with pulmonary fibrosis, all that is meaning is there's scarring, there's scar tissue. So just like I always point this to my patients. So this is a scar right here of something stupid I did in the past. It actually used to look a lot worse. The lungs are the same way. If you have a severe COVID, which is, okay, so if anybody, I'm going to point this out and on my beliefs, So COVID, bad, right, guys? That's why I did what I did to do the best of my abilities to prevent from myself and my fiance and my family to get COVID, because I've worked with it firsthand in the ICU and ER. I've seen a lot of death and I've seen a lot of things. So based on that, you can get pulmonary fibrosis from COVID. And let me go into detail with that, what I'm saying. With scarring, you can get scarring for life. You can get scarring for life, and thus you have breathing issues. And what that means is when I see pulmonary fibrosis or some type of other issues, or like post-COVID, I'm thinking there's scarring. Without even looking at this, I'm thinking the diffusion capacity is also going to be lower. Why? That means all the lining is going to be thicker. That means the ability that you're going to have to get in the gases that we're breathing in right now, so that's the oxygen, carbon dioxide, nitrogen, and various gases, the ability for you to breathe in is going to be a lot harder. So that's why these patients have to have oxygen and all that good stuff. So that is why. So I'm thinking everything's going to be low, but I don't know what else is going on. Maybe this patient has a smoking history, or maybe some type of trauma or anything that causes this. Maybe there's cystic fibrosis. So that's where you get your mix. So yes, I have seen mix before, and it's popular. You can have somebody that has pulmonary fibrosis, based on some type of scarring. Maybe they, maybe they have COVID. Maybe they had some type of other disease. Maybe they had pneumonia that caused pulmonary fibrosis. Maybe they had some type of other issues or trauma that caused this. Or maybe you have it where their body just does it itself. So I'm not going to go into that too much right now. That's more of a disease and processes class. But so with pulmonary fibrosis, as a good therapist, you need to look at their history. You need to look at what's going on and what's going to happen. So I'm going to look right here, and it says dyspnea with exercise. Okay, well, that makes sense. You have pulmonary fibrosis again. So I'm thinking the diffusion's low. Let me find, on doing the test, we'll figure out how low. Okay, well, let me go down the line. So cough, yes. Okay, well, they have pulmonary fibrosis. It makes sense. Persistent makes sense. Okay, well, they're a smoker. So now I'm thinking there's going to be some type of mix. And then cigarettes, yes. Okay, well, and then 35 years. Okay, and they stopped 18 years ago. So let's see how the severity is. And so, guys, and again, I'm not going to go into too much detail with this, but once you're obstructed, once you start ruining the elasticity in your lungs, you can't get that back, okay? You could go to pulmonary rehab and try to better the quality of your life. You could do a bunch of things, but I'm not going to get into that right now. I'm talking about more of PFTs right now. So what I did before, spirometry. Again, I'm looking at the speed and your volume. How fast can you blow everything out, and how much can you blow everything out with one good breath? So I'm starting with what I said, my ratio. 70 and higher, I'm starting to think it's going to be normal restricted. Or 69 and below, it's an automatic obstruction. But don't get me wrong, I've seen some ones where they're 70 or higher and they are obstructed. But again, you have to look at other numbers to diagnose it. The only one that you can automatically tell it's an obstructed is when it's 69 below. Reason why is because of the ratio, FEV1 over FVC. That means that's telling me the FVC is low. So this one right here, 75. Okay, well, I'm starting to think that it's normal restricted. Let me go to my other normals, which is the FVC or FEV1. Well, okay, well, I can tell right there, FEV1, he had a hard time blowing out. Or is this, yes, this is a male. So he had a hard time blowing out 57, and they didn't have that much air to blow out. So what does that tell me? So the 60% tells me, again, FVC, the total amount of air that you blew out is not good. That's 60%. 80 and higher is normal. So he didn't have that much air to blow out. Okay, well, that's exactly what I said. He's restricted. I'm automatically starting to think he's restricted. 57, that's well below normal. So that I'm starting to think that's based off speed, your forced expiratory volume over 1 second. That is not good. So I'm thinking there's a mix already. I'm already thinking there's a mix. So based on these numbers, I'm already going to give a breathing treatment. And I'll go over that in a second. And then your 25, 75, well, they took a long time to blow out. again, 60% and higher, it's normal. 43, that's crap. That's crap. That's not good. So again, PEF, that's more of, I'm looking at their effort and based on reproducibility. So to tell when you need a breathing treatment is as the normals, is when you start, like I said, with the obstruction. When you find out if it's obstructed, that's when you do a breathing treatment. The numbers that you look at are your ratio. So again, if it's 69 below, automatic breathing treatment, no matter what. If your FEV1 is, this is a little different with the breathing treatment. If this were to be normal, it would be an automatic breathing treatment if it's, I want to say, if it's 59 and below. If it's 59 below. But the only way to really tell is this number would also be low most of the time if the FVC is low. So that's why you have to go through each one to determine if it's restricted or obstructed. But based on that, that's obstruction right there. So that's an automatic, this right here, just that. So this is, I wouldn't do a breathing treatment here, but this tells me to do a breathing treatment. Also, another one to tell again, so if it's 59 below, that's also obstructed. This also tells me that it needs to be a breathing treatment. So if this was 65 and 65, yeah, that'd be restricted. But this is telling me there's obstructed. This is automatic need for a breathing treatment. So you give your albuterol, your Zopanex, maybe a Duaneb, some type of bronchodilator, a rescue bronchodilator, so we could see improvement. Another one you could look at is your residual volume. If you see some type of air trapping, that's when you would need to do a breathing treatment. So again, over 120, that's automatic air trapping. You got to do a breathing treatment. And again, that's when you got to start doing clinical. You got to do clinical thinking. If your TLC is super low, but your residual volume is normal, well, why would it be normal if your total lung capacity is low? It shouldn't be that. So then I'm going to go to my diffusion capacity. So this is what I was saying. So depending on the diffusion capacity is the severity of how bad it is. This is the quality of life. This is the quality of life for patient to see, you know what, maybe this is why they have shortness of breath with exertion. So let me look. So again, I'm just going to look at my DLCO. Yes, in textbook, you might look at other numbers. But based on, to make it real simple, I'm going to look at it. 80 to 100 is normal. So let's find out. 62, well, damn. So 60 to 59, I'm sorry, 60 to 79 is going to be a mild decrease in diffusion capacity, and they are actually almost moderate. So, well, go figure that they have diffusion, they have shortness of breath with exercise. I would even doubt that he made it up that with rest. He probably has rest and he doesn't even know it. Dyspnea, he doesn't even know it. So, based off that, it makes sense, again, with the scarring, with pulmonary fibrosis. So then I'm going to go to lung volumes, okay? Lung volumes is going to tell me, again, I'm looking at two numbers, TLC and residual volume. And I'm not even looking at these numbers so far, okay? I'm not even going to look at them. TLC, I'm expecting the number to be low. Why? Because this tells me this is restricted. I'm expecting it to be low. The residual volume, I don't know if there's air trapping, but I'm going to find out right now. So you can't tell if there's air trapping based off this. You could just tell there's obstruction. So let me look at the TLC. Okay, well, I was right. 76%, which again, 80 to 100 is normal. So this is low, okay? And then let me go to my residual volume, 95. So this is exactly what I've been saying. Yes, 95 is normal, but why would it be normal if you have a low TLC? So there is air trapping. So this is another indication for a breathing treatment. So before I even go into the bronchodilator that I'm going to give this patient, so based on spirometry, they are restricted, obstructed, mild decrease in diffusion capacity, restricted, and they have air trapping. So now I'm going to give them a breathing treatment. How you do this based on a therapist. And guys, this is not only goes for pulmonary function testing, but this also goes for future reference. When you are a therapist, if they have some type of cardiac history like AFib or something, and they do take breathing treatments, you got to make sure if they take Zopanex or Buterol. Now, yes, Zopanex decreases the chance of some type of the effects of it, high heart rate, palpitations, headaches, and all that good stuff. But it can still happen. So find out with that. But I did Duoneb. The only reason why I do Duoneb is you start doing Duoneb kind of when you go into the future reference. You do Duoneb when you have a smoking history. But based on this, to dumb it down, based on the board, just do albuterol. Albuterol is the way to go. So here's me doing the post-treatment. So here's the change. So based to find out if it's a good change, your FEV1 needs a change by 12%. But your 25-75, if it goes up significantly, that tells me there is some type of small airway disease, meaning that their lower airways maybe lost their elasticity. They're not able to blow out as much, which kind of would make sense right here. So let me look. Well, they weren't able to blow out as much. Maybe they didn't take as deep breath in. They blew out 1% more than the FEV1. Okay, so automatic, this is not a significant, improvement with the bronchodilator. But let me look at my 25-75. 51%. Okay, well, these two go hand in hand. So if they weren't able to blow out more, the machine's automatically going to record a higher 25-75. But this is only a 4%. This is 51%. So this goes back to 0. If they were able to blow out a little bit more, this would probably be maybe 35%, 40%, somewhere around there. So I still think there will be an improvement with the lower airways. So there's I would say based on the computer way, mild decrease in diffusion capacity. Mild improvement with the bronchodilator. So again, I went over everything. Let me look at interpretation wise. So minimal obstruction effect. Airway obstruction is confirmed by the decrease in flow rate at the peak flow 25-75 flow curve. And it's right here. There's a mild restriction lung defect. Again, that is confirmed with the TLC. There's a moderate decrease in diffusion capacity. Now, I know I said mild decrease in diffusion capacity. The reference that we are using at this place at the Pulmonary Sleep Institute, our machine is just a tad bit outdated. So it's gonna have a little bit different values. Updated values now, this is a mild decrease in diffusion capacity. But since this is a little outdated, this is just going to say moderate decrease. So based on your boards, just say this is a mild decrease. And then you have FEV1 changed by 50, the FEF 25-75 changed by 51%, mild response to bronchodilator. So now we can go based off that. I'm going to go a little faster since it's already been 43 minutes and probably lost more than majority of y'all. I'm going to go over it quick. Okay, well, cancer. Okay, smoking. So I'm assuming there's going to be some type of obstruction. So real quick, 65% with your ratio. It's less than 70, automatic obstruction. Then I'm going to go to these two. Okay, well, these two are normal, but automatic obstruction. Let me look at my 25-75. Well, now it's confirmed with my 25-75 that's 38% because it's lower than 60. So there's automatic breathing treatment and it's automatic obstruction. But let me look at everything else. DLCO, usually with COPD, you're going to have a lower diffusion capacity, but I have seen it where the diffusion capacity has been normal. But let me look at my diffusion capacity to see what it is. Well, damn, it's 44%. So it's close to being severe decrease in diffusion capacity. So based off this, again, 40 or higher is going to be a moderate decrease in diffusion capacity, almost severe. And then lung volumes, well, 104. Okay, well, that's normal. Again, this is normal. And then this is 103. Yes, it's over 100, but clinical thinking, If this is going to be high, this is going to be high. So both of these, I'm thinking these are normal, but there is some type of obstruction here. So I'm going to do a breathing treatment. I do the breathing treatment. There is a change right here. Yes, okay, this is not significant, but there's this 15% change right here where it improved the airways. Again, so 2575 is based on the small airways. So I do think she has some type of a small airway disease, but again, she has obstruction. So I'm going to go down, moderate obstruction lung defect, and that's based on the 65% and the 38. It's confirmed by the 50-75% which is up here. And then, and the only reason why it's saying that is because her FEV1 is normal. So she starts slowing down at the very end, which you could see, let me focus it in. She starts slowing down right here. So she blew out real quick, but then she wasn't able to get it out after that. So that's why it's saying that. Lung volumes are normal, moderate decrease in diffusion capacity, 25-75%, changed by 15. So yeah, it says insignificant. So that's why this isn't on the boards, because this changes frequently with, like I said, with authors, references. So, so based on that, yeah, it says insignificant. It did help just a little bit. I would do it just to help. But based on these numbers, breathing treatment doesn't help. But you would still need to do a breathing treatment based on this test. So let's move on to the next one. Here's my last one. Here's another pulmonary pulmonary fibrosis. So again, let me look at a history because I'm a good therapist. Okay, well, they have shortness of breath with exertion. I'm expecting it. Okay, well, they were a smoker. So let me go over it real quick. Spirometry. Okay, well, my ratio's above 70, so I'm thinking it's either going to be restricted or it's going to be normal. But let me keep going. Okay, well, FEC tells me it is the amount of air that they blew out is lower than normal, so that's restricted. Okay, and this is a lot lower than normal too, the speed. So they also have some type of obstruction. Even though the 25-75 is it's normal, based on this, there's some type of obstruction. So based on that number, I need to do a breathing treatment. But let me go my diffusion capacity next. Lower than 40. Again, pulmonary fibrosis. People who don't believe in COVID. Non-vacciners in your class. This is what it does. Right here. You're in respiratory. Why don't you believe in COVID? I'm not going to go into detail with that. But 40% and 39% and lower, again, that is because you have a lot of scarring, which can tell me why that's also restricted. This is a bad restriction right here. So let me look at my TLC. Restriction. It's confirmed now. And then my RV. This is also smaller too. What's restriction? But based on just that number alone, let me do a breathing treatment to see if they have like reactive airway disease. Well, it didn't work. Obviously. 1-1, it's not 12%, and this didn't even work at all. She didn't even blow out as fast. But, so based on this, based on the FEV1, there's a moderate obstruction lung defect. Obstruction lung defect is confirmed by decrease in flow of the 25, 50, and 75%. So all that is when she blew out, and then it just slowed down, which would make sense with the FEV1 being slow, and then, you know, this is not too fast. And then, so moderate restriction lung defect, yes. There's a severe decrease in diffusion capacity, and this is also an insignificant response to bronchodilator. That's basically it. There's nothing too much more into to PFTs. It's really simple. If y'all have any questions or y'all see me later in clinical in your clinicals, the ones who actually do it or come with us, I explain it, and I try to do as best a job as I possibly can. So here, Roxanne, one last time. So real quick, I'm going to do this for the ones that don't have, everybody should actually have a pulmonary function test rotation. But just in case you're not with someone as good as me, or you're not or if you don't go to Maine Methodist Hospital, I'm sorry, you're not with the best. I'm kidding. I'm just joking. I'm not meaning it to anybody. I came from Maine Methodist. So This is the last part. I'm just going to go over how I instruct it. So I'm going to say, future Mrs. Hernandez, my name is Nolan. I'm the respiratory therapist here. I'm here to do a breathing test with you. This test is here to evaluate the functionality of your lungs. This test does not diagnose what you have, but this helps the doctor. It's a therapeutic tool. It's a diagnostic tool. It's a tool to help further what you have. And based on that, then you have to start doing other things. But then I also say each test that what I do, I explain and what I'll do and what they mean. The first test is spirometry. It's based on speed and volume. How fast and how much can you blow out with one good breath? So what you're going to do is you're going to start breathing normal. And when I ask you, I'm going to say take a big deep breath in. You take that as big as you can. So then I'm going to say now pass it out. And I want you to force it out until you're completely empty. Towards the very end of your breath, it's going to start feeling like you're straining yourself or like you're already empty. I'm going to tell you to keep going, keep squeezing. Once I see you're completely empty, I'll let you know when. I'm going to say take a big deep breath in. You take that as big as you can. So, and that'll be 1. So to recap, normal breathing, big deep breath in, blast it all the way out, and deep breath in. I'm not going on scenarios with you because the board's cut and dry. Do you know it or do you not? DLCO, what I tell them for that is you're going to start breathing normal. And when I ask you, I'm going to say take a big deep breath in. You're going to take that as big as you can. So then I'm going to say let it out all the way. You're going to go. So still faster than normal, but not as hard and fast as we just did. Same thing though. Empty your lungs. Once I see you're empty, I'm going to say take a big deep breath in. You're going to go. And then I'm going to say now hold it. You're going to hold it for 10 seconds. And the reason why I say 10 seconds is because some people who are restricted, they're able to go and they're already there. So you have a 4-second time where you're able to suck in all the way because some people are, like I said, they're not, I wouldn't say not all there, but they just don't have that motivation or they don't have that desire to do it. They don't care about the test. They hate life. They just don't do it. So it gives the people 4 seconds to go. So if they don't suck it in within 4 seconds, they're not trying. They're being silly or they're being stupid. They just don't care. So that's why I give 4 seconds. So I always say 10 seconds. So, and then you hold it. And I give a countdown. After the 10 seconds, I say, let it out. And you're going to go. So what I explain to patients, the test that we're doing here, we're seeing how well you're able to diffuse or absorb the gases that we're breathing in right now. So currently right now, we're breathing in oxygen, carbon dioxide, nitrogen, and a couple of the various gases. So what we're doing for this test is we're actually giving you a gas that we can measure. So when you're taking that big deep breath in and holding it, we're actually giving you a gas right there and we're letting your body diffuse and absorb it. So when you're breathing out that last time, we're actually measuring that breath. So that's all we're doing. And then for the last part, it depends on which way you do. If you're either going to do nitrogen washout or plasmography. Again, test taking, plasmography is the more accurate way to do it. So just because of that, I'm going to do plasmography. What I say is you're going to start breathing normal. That's your tidal volume. Then you're going to breathe out all the way until I tell you to. That's going to be your ERV. Then take that deep breath in. That's going to be your vital capacity. Then you're back to normal breathing. So for this test, I'm going to close the door. Again, Boyle's Law. I'm going to say put your hands against your cheeks. The reason why is because your cheeks tend to do. And that can affect your resistance results, your raw. I'll let Mitchell go over that with you. I'll let Krista and Kristen, whoever teaches PFTs or whoever assists her, but I'm pretty sure it's Krista still. Whoever assists you, I'll let them go over the raw. But anyways, so you put your hands against your cheeks so they don't blow up, and you're just gonna do it nice and simple right here. Just and you're just gonna do it right here, nice and easy. So what I usually say from out here, I'll be guiding you the whole time, telling you go deeper, faster, slower, smaller. Once I see that we got the speed and rhythm that we need, I'll tell you, good, here it comes. What I mean by that is it blocks off. And that's how I won't say I'm going into too much detail, but it blocks off and you're able to tell a lot with that part. You're actually able to tell with how much volume you have and your resistance. I won't go over too much with that. But it basically blocks off. It really does feel like you're blocked off and you really just go. So that's your plasmography. Nitrogen washout, that beginning is the same, but instead of putting your hands to your cheeks, That's when I always say, you're going to start getting oxygen. All I want you to do is go. So people who are obstructed, it's going to take them a lot longer to blow out the nitrogen washout. You can only blow out for 10 seconds. I've seen somebody do that where their 25-75 was like 5. I'm not exaggerating. So people who are restricted, it usually lasts about a minute. So I usually say it's going to take about 1 to 2 minutes, but usually I'm pretty good at what I do. So if I know they're severely restricted, I usually tell them, may take about 4 or 5 minutes, but I'll let you know when we're about to end. So I usually tell them, but that's basically it. If y'all have any questions or Mitchell needs me to clarify anything or dumb it down even more, I will. Like I said, spirometry is all about speed and volume, guys. I try to explain this to my classmates, but now that I know more, like I said, start with your ratio. You could go to your FEV1 or FVC. They tell you basically what I was telling you earlier, whether it's going to be, remember your FEV1 is all about speed, your FVC is about how much you're able to blow out entirely. 25-75 is all about your speed. That's your lower airways. You can tell if you have lower airway disease with that or small airway disease with that. Diffusion capacity, how well you're able to absorb what we're breathing in right now. If it's lower, that's when the people are going to have trouble breathing. And then your lung volumes, it's simple, your total lung capacity. Like I said, the 2 numbers that I look at the most are going to be your total lung capacity and your residual volume. TLC, it can be high, it can still be normal, but you need to look at the whole picture. This whole thing, it all adds up. And that's basically it. Like I said, the people who have me, I know there's a couple people that really caught on pretty well with me pretty quick. There was someone who had amazing notes. Ask her. She stunned me with how much she listened to me, and I really liked that because I felt like I wasn't wasting my time. So, like I said, I gave you like 4 or 5 questions easily where she has it. Guys, I graduated 5 years ago. They don't update it too much unless the boards change up. So we take the same test. Other questions that y'all may have, which is how many questions do we have on the TMC, the time multiple choice. I personally had about 11 or 12. I'm lucky. I'm glad I know it. Some people didn't have that many PFT questions. Some people have more hemodynamic questions. Some people have more equation questions. But I'll tell you what, I'd rather know my PFTs than knowing those stupid alveolar equations that we never use ever again in our career. And if a doctor ever asks me to do that, I will tell him, I don't know it, I don't remember it, I don't want to Google it, I'm not going to do it. I'll try to change the subject. Y'all know what I'm talking about. The first and second semester, never will see it again. I would say remember your pico, whatever it is. But, guys, real simple. If you need me to dumb it down even more, like I said, I could do that. But I'm sorry I took y'all too much time. Like I said, if this isn't good enough for you, please tell Mitchell. Tell her, write down some questions. I'll make another YouTube video explaining everything that you'll ask. For the nerds in your class, I know there's always nerds. Don't overdo it. Don't overdo what I'm saying here. I'm literally dumbing it down for you because I remember the boards. Again, the boards are not asking what your ranges are. Your boards are asking, do you know it or not? Are you able to tell if it's obstructed or not? It's not gonna be a borderline 41. Is it severe or is it moderate? And no, it's gonna be like a 50. Do you know it or do you not? It's gonna be a 20. Do you know it or do you not? For your diffusion capacity. So it's and all the numbers that I gave you, all the values I gave you, those are your most important ones. I know there was a lot more in there that you're able to tell, and yes, they are important, but for the boards wise and for Mitchell's test, you don't need to know it. You don't. So I just recommend that. Something I didn't say, last part, spirometry, you need 3 reproducible maneuvers. They need to blow out for at least 6 seconds to be acceptable. If it goes longer than that, it needs to at least go for 15 seconds if it hasn't hit that green light yet, meaning if they're still continuing to blow out, it needs to go out for 15 seconds. I've gotten obstructed people to go for 20 seconds. But yeah, 6 seconds. Just remember that one. That's a question on there for spirometry. It needs to at least go for 6 seconds to be acceptable. If not, it's not acceptable. Diffusion capacity. Diffusion capacity, you need at least 2 maneuvers that are acceptable. The numbers that I showed you, they need to be within 2%. And then you also need to have it within 80% of your vital capacity or your inspiratory capacity in order to be acceptable. I don't think that's a question, but you at least need 2 diffusion capacities that are close together. And again, 2. So if the percentage is 80, the other one needs to be, or I'm sorry, if your value itself is like 22.2, the other one needs to be about 24.2, and that's 2. If it's 24.3, it is not acceptable. I mean, not reproducible. You need to do a third one. And then you still need time between it for your body to expel that gas. And then your lung volumes, nitrogen washout, you're only able to do it once because you blow out the nitrogen in your lungs. I want to say it's 15 to 30 minutes. Remember, you're only able to do it once. Your plasmography, you need at least 2 that are reproducible. I want to say. It might be 3, but I want to say 2. But other than that, we're all good. Like I said, if you have any other questions, ask Krista Mitchell to ask me. But Krista Mitchell's good. Respect her. She helped me pass my boards. I passed my Clin Sims and my TMC both at the same time, the first time. And I was the first one to be registered in my class. So let me know if y'all need help, and let Krista Mitchell know if you want any of my assistance. Other than that, thank you guys. Peace out. Go see Phillips. Woo!